So 80-year-old male with chronic blurred vision, right eye. And patient is an 8-year-old male, retired oral surgeon. Patient notes that the right eye vision is not as good as the left eye. He is not particularly bothered by the vision in the right eye. The vision has been worse than right eye in the right eye than the left for a long time, several years. Visual acuity is 2032 minus 2, left eye 2025 plus 2 without glasses, and IOP is 9 in both eyes. His past medical history includes enlarged prostate, hypercholesterolemia, hypertension, MI 2014. He has had cataract surgery 10 years prior and by Dr. Hall at that time. Also a history of heart stent and hip repairs, and there's a list of his medications. And here's the first photo.
The color fundus photo of the right eye. The media looks clear. The nerve, it's enlarged. It looks like there's maybe some PPA. The color looks a little papular, or a little bit of pallor. The vessels, it's a little bit tortuous, notably inferiorly. The macula here is normal. I do see a little bit of just little hypopigmented specks. Just these little right there.
She's looking at the bottom. Okay, you're seeing the specks. She's looking down by that vessel, the artery. Right down a little bit. Down, 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 stop right there.
And then this area here, it looks a little reddish, maybe some heme, with a small punctate hypopigmented spot as well. And then there's also this other notable area, just a little hypopigmented specules kind of around, and then one up here as well.
Thanks, Maverick.
Oh, I think this one's my mouse, right?
Was that your mouse? Okay. All right, go ahead.
All right.
I think we did do that.
Oh, you can see that.
And then the fellow eye, color fundus photo of the left eye, media also looks clear, similar appearance of the nerve, a little bit of pallor, and then what I believe is some peripapillary atrophy. Also some tortuous vessels, and then similar appearing hypopigmented spots kind of scattered throughout the macula. Here it's a more notable inferiorly. One more hypopigmented spot up here. And then maybe, what is that? And that's normal. Never mind.
All right, we're a little bit behind, but keep going.
Okay, so
This is the right eye.
OCT of the right eye, there's a lot of intraretinal fluid cysts. And then this more hyper reflective area here could be maybe like an aneurysm, microaneurysm.
Good. Yeah, those look like, those do look kind of like vessels, like edges of vessels.
Here it's highlighting the choroid thickness, it's increased. And then the remainder, the foveal contour is intact, no fluid centrally. There's some areas here, I think that's temporally.
Yes,
Temporally.
this is the left eye now.
Of the left eye, there's some areas of maybe some drusen, a little bit of IOSO junction, just changes here.
Okay. The autofluorescence to the right eye issue. So what do you see there?
So
Now that postage stamp is because we first did a 30-degree autofluorescence. So you see the little square? That's an artifact. So a lot of times I'll do a 30 and then a 55.
So area of hypoautofluorescence superiorly, and then hyper autofluorescence kind of speckled throughout, or I think I got that backwards.
Yeah.
Yeah, so
So, okay.
hyper autofluorescence superiorly and then hypo autofluorescence kind of throughout the center part of the macula. And inferiorly here, a couple spots here.
Now you saw in the OCT the cysts, right? And this is the right eye, that's the one that had fluid. Do you see the pigment spot in the center of the macula that's supposed
Yeah.
to be round? What do you see there?
It looks irregular, almost
Right.
looks like a Mercedes sign.
So you'll see that in cystoid edema. If there's cysts, the autofluorescence, it displaces the macular pigment, which is in the axons of the cones. It'll displace it and then you'll see the funny pattern. The macular pigment doesn't look right.
And then these. Okay, so this is the left eye. Similar appearance here, so the hyper autofluorescence with surrounding just speckles of hypo autofluorescence. And then this area as well. Inferiorly looks like a hyper, or also hyper autofluorescence ring with hypo autofluorescence in the center, and then the center part of the macula appears normal.
Okay, and then do you want me to pan through some of these? I can go back and forth if you like.
Go back. That's good. And then she can ask Heidi.
And then I'll go back to the start again.
So what do you see there in that plane? You go back to the 30-degree one.
So the center of the macula, there's a lot of speckles of looks like, I think the next one, it increases in size. Do you mind going to the next one? Yeah, I think so.
So how do you describe those? Hyper, hypo?
I would say hyper,
And this is fluorescence because it's a fluorescent.
hyperfluorescence, and then these surrounding ones, it's more obvious that it looks like the borders are more irregular, so maybe leakage.
Oh, you have to follow.
Yeah.
Go ahead. And then how about down below? There's a couple different areas that are kind of funny.
Down below also hyper fluorescence. These look more punctate and defined borders, so maybe some staining. But
So
we'll have
where do
to-
you think, the two of you, where do you think though, if you go back to the 30-degree Maverick, where do you think those lesions are? At what level? You can't tell the level, but just based on the anatomy.
Intraretinal? I guess I'm not really seeing my vessels go above or below it, so it's hard to say.
Yeah, it looks like it's the vessels. It's intraretinal. It doesn't, do you think it's bruising? It looks kind of like the vessels are funny, doesn't it?
How could you tell it's intraretinal other than looking at the OCT?
It's just the OCT.
Okay.
I guess what I was thinking was go back to the 30. If you look at the capillaries around those spots, they're not normal. I guess that's what I was kind of yogging in on. If you look at the spots and then you look at the little vessels around them,
Mhm.
both up there and then down below, the capillary network there is much more visible than you
Oh, okay.
typically see.
So a more lacy appearing.
Yes, I think so it looks to me like it's the vessels that are, I think just because of those cues.
And they're on both sides of the midline here.
Yeah, that's the other thing. In what distribution are those abnormalities? Okay, good, thanks. Sorry, I'll let you speed up, tell you to speed up tonight.
Okay, and I can move on to the left eye here.
Okay, so left eye, some areas also of hyper fluorescence. This one looks like it's at the terminal area of the vessel. And then close to the nerve here, also some areas of hyperfluorescence, some are in punctate, and then just kind of just diffuse hyperfluorescence. Here I don't really appreciate as much of the lacy networking. on the
Yeah, the
side.
vessels look pretty good in the side. Exactly, that's one of this case is this case is a little confusing. I thought.
And then
There
centrally-
are two diagnoses for this case, by the way. So
Yeah, this is, we don't usually, this is done different than the usual one.
Okay. So I think that it's the late phase.
Yes,
so,
well, you're a minute, it's not super late.
Okay.
You could probably go one more. Is there one more on this or no?
Yeah, there we go. And then there might be, yeah, so I have this here. And then let's see, 30 degrees. And yeah, okay. Show me it.
Yeah,
Move
so
on.
what do you- Yeah, why don't you move on? Sort of through the spots.
All right, so we have a differential.
So it's something that's gonna cause, I believe CNVM, in the right eye, there's like that lacy vasculature.
Well, that's, you're saying choroidal neovascular memory, but it looked like the retinal vessels were kind of funky looking.
Mm.
So sort of capillary, retinal capillary. If you go back to that retinal capillary one in the right eye. One more, the 30. So basically what you've got is your capillaries temporal to the fovea are funny looking.
Mhm.
Your capillaries infratemporal along that vessel are kind of funny looking. And that's mostly it. And then there's a lot of RP. The guy's 80, you know, so there's a lot of RP irregularities. So you've got the funny looking capillary vessels, and then you also have the thickened choroid. And then you have those multiple PEDs. If you go to the other eye, if you look at the those are all little drusen-like PEDs, those spots.
Mm.
So those are all deep filling, you know, and he's 80, but it just doesn't look quite like macular degeneration. So your differential's got to take into account. And again, Maverick said it's two different things are going on with this eye. The capillaries are funny looking in the right eye, and then both eyes have these patches of, you know, choroidal thickening and patches of hyperfluorescence.
Mm.
So what would, if you said the capillary, so just do the capillary abnormalities, what would cause that? Like, what's your number one diagnosis for retinal capillary abnormalities? Especially out here.
Diabetes.
Yeah, so diabetes is like number 1, 2, and 3, but he's not diabetic. So he's not diabetic. So then you get down to your next most common retinal vascular disease that you see in the clinic.
Hypertension.
Well, hypertension, but doesn't really manifest. But yeah, what else do you guys see a lot? The retinal vessels.
Vein occlusion?
Yeah, vein occlusion. So vein occlusion is your second. So I think your first most common is diabetic, second most common is vein occlusion. And the thing about this, which I'm still not sure of, is it didn't look to me like it was one vein. So if you can't peg, if it's a vein occlusion, if you can find a vein, but if you can't find a vein, which I don't know, this might have been an infratemporal vein occlusion, but it didn't really have collaterals. So then you got a male who's got retinal capillary abnormalities in one eye that are a little bit subtle.
Mm.
So what might that be? In a guy. You guys can help that. Your seniors are all saying codes. So it could be codes for one of the telangiectasias. So those are kind of, and then let's say the patient had cancer and got radiated. You know, it could be radiation retinopathy. And then you've got these really obscure retinal dystrophies. So, but you're talking like diabetes, like vein occlusion. Then you get to these really rare ones. So I was telling Maverick, this could be codes. I still might be a vascular occlusion that was just subtle, or you do see double vein. I think 10% of people with vein occlusions will get a second vein occlusion. So it's possible to knock out two different areas, but it wasn't quite right. So that's your one differential. Then you've got those PEDs and the bumps in the thick choroid. So what do you think about that one?
Oh, wait, I thought you told them already, so I just moved forward. Sorry.
Her eyes were just sort of looking towards the screen. And she's like, huh. So yeah, so there's central serous, but a diagnosis of central serous in an 80-year-old is a little bit edgy. So then you get into the age-late maturation or pachycard. If you go back to that autofluorescence image, just real quick, and then I'll let you do your discussion. The autofluorescence, especially in the left eye, that looks like central serous. So if you see autofluorescence, you got patches, funny looking patches that are not normal. That's usually central serous. I've seen that.
Actually, on my last slide, I have a link to Aiden where they have almost identical to this mirror image where they show a case of chronic CSC, and you can pan.
Yes, and you can see those. The only thing that's not perfect about it is there's not a gutter. If there's a gutter, that'd be great, but you can get patches without a gutter. All right, I'll let you go, Maverick. Go.
Okay.
No, it's autofluorescence. You can see, and it's not active. And you always see smoke extracting 10% of them. All right, go ahead.
As discussed, differential being central serous chorioretinopathy, coats, neovascular ARMD, polypoidal choroidal vasculopathy, retinal venous occlusion, MACTEL, hypertensive choroidopathy, and so on. So the diagnosis is central serous chorioretinopathy with possible Coast disease. The retinal capillary abnormalities are consistent with either a BRVO or Coast disease on OCT and FA, and there are no collaterals, and the capillary problem is not in the distribution of a specific retinal vein, therefore presume late presentation of Coates disease. It is possible that the chronic CSC at some point caused enough damage to the retina to induce retinal capillary damage. However, that has not occurred previously in Dr. Cohen's experience, is what he was mentioning to me before, and further discussion is welcome for that. So,
Where if we had like 5 attendings in the room, everybody could talk about it, but I'm the only one here, so guy. Right,
So central serous chorioretinopathy is the fourth most common retinopathy. Typically occurs in males in their 20s to 50s who exhibit acute or subacute central vision loss or distortion. So think like working age, stressful males, characterized by serous retinal attachment with or without pigment epithelial detachment. Several studies have revealed choroidal filling delay, choroidal vascular dilation, and choroidal vascular hyperpermeability. So for etiology, no underlying pathophysiology mechanisms have been proven, but CSC is thought to occur secondary to hyperpermeability of the choriocapillaris in association with retinal pigment epithelium dysfunction, causing a serous attachment of the neurosensory retina. Reoccurrence occurs in about 31 to 50%. Coexisting choroidal neovascularization may be present in up to 20% of cases in individuals over the age of 50 years old. So steroids, both endogenous and exogenous, have the strongest known association with CSC. Furthermore, associations with having a type A personality seems logical given known increased glucocorticoid release with stress. It is therefore the only inflammatory choroiditis not proven to be associated with infection that is precipitated or worsened by glucocorticoids. Increased choroidal vascular permeability is postulated to occur as a response to epinephrine-mediated vasospasm that is potentiated by steroids, leading to choroidal ischemia and vascular hyperpermeability. A study found scleral thickness measured by OCT was significantly greater in CSC eyes than in normal control eyes, although no differences were found in spherical equivalence or axial length. Thick sclera may have a role in pathogenesis of CSC. Thick sclera seen in CSC eyes may increase the vortex vein resistance, reduce choroidal venous outflow, and induce disturbances of the choroidal circulation and posterior pole. In addition to disturbing choroidal venous outflow, thick sclera may be impermeable to transscleral outflow, leading to fluid accumulation in the suprachoroidal space. This cascade of events can lead to the secondary dysfunction of the RPE and accumulation of fluid in the subretinal space.
I'm just going to throw in real quick. So that's a lot of that's the etiology for posterior uvula fusion syndrome. And I recently heard some surgeons discussing whether anyone's done scleral windows in severe central serous, and no one has really tried that, but it's an interesting, the sclera is interesting. All right, thanks, go ahead.
Okay, yeah, and actually for the management, I did list a scleral window because I actually did see it mentioned as if it's been historically done. Yeah, but subfoveal choroidal thickness in CSC was measured, average 424 microns, give or take 101 microns versus 324 microns, give or take 91 in control group, and per BCSC, subfoveal choroidal thickness measured in vivo among healthy volunteers with a mean age of 50 years to be approximately 287. So this was straight out of BCSC, a nice little example of showing the subfoveal choroidal thickness measurements here. And as you have it in first normal eye, then we have CSC in a 44-year-old male, then a 57-year-old male, then a 63-year-old male. So you can see the different thicknesses there. Etiology, other associations described, just worth mentioning is has been an association with Helicobacter pylori, MDMA, sildenafil, topiramate, MEK, ERK inhibitors, and obstructive sleep apnea. Demographics.
Maverick.
Oliver has a question.
Maverick, could you mind going back to the pictures from on the previous slide real quick?
Yeah.
Yeah, that one. As far as the retinal layers for C, Dr. Cohen, is that like normal for? See, sorry, it looks like
For C?
ischemic and
That was like syphilis, wasn't
it just doesn't.
it?
It's always on the
C's-
differential.
C's a funny, we have a general, it's like syphilis. Yeah, C is a funny looking one. I think C is supposed to be chronic,
Okay,
so it's probably a chronic central serous and the Jones don't think.
okay, cool. Thanks, Maverick.
Thanks.
So for demographics, most patients, as I mentioned before, between the ages of 28 to 68, average age of 43. Those who are over 50 years of age are more likely to have bilateral disease 50% of the time with RPE loss and choroidal neovascularization compared to those less than 50 years of age, which is 28.4%. The male to female ratio is 3:1, and similar prevalence of CSC was noted in Caucasians, African Americans, and Asians. Systemic associations include endogenous hypercorticolism, so Cushing syndrome, hypertension, sleep apnea, pregnancy, and psychopharmacological medications. So findings, you can see round or oval serous macular detachment with hemorrhage with small yellow subretinal deposits in the area of neurosensory detachment. You have RPE, PEDs, may be seen on OCT in up to 63% of eyes, thickening of choroid, posterior loculation of fluid in the deep choroid. Macular RPE modeling can be found in cases of recurrent or chronic CSC. And typical FA findings are ink blot appearance in 31%, smokestack pattern 12%, and minimally enlarged spot 7%. And here's examples of those white dots and smokestacks there. You can see. So management as CSC, it usually resolves spontaneously within 2 to 3 months. Observation is currently standard of care for newly presenting cases. Discontinuation of steroids is recommended. Try telling your patient to relax, always goes over well in clinic as well. For chronic CSC, recurrent CSC, and acute CSC in functionally monocular patients, you can also use anticorticosteroid therapy, eplerenone. Low-dose aspirin was also recommended to decrease plasminogen activator inhibitor 1. Also, in the case of if they have H. pylori, you could treat that. Beta blockers is also something available, and then you could do anti-VEGF for coexisting choroidal neovascularization. There's also micropulse laser, PDT, and then I guess not really performed now as laser or scleral resection though was listed. And then this was that example. I don't know if you could see my
Oh, yeah, we can.
browser.
Yeah.
Uh,
I think it's actually
is it loading?
not very well.
For the management, how do beta blockers affect CSCR? Is it like to treat their underlying systemic disease, or is?
I don't know, I've not seen beta blockers used. Beta blockers have this magical effect on capillary angiomas.
Oh, okay.
So maybe it's somewhat related.
Yeah, I think it did have to do with decreasing the hyperpermeability or the venous tension. I can't remember exactly though. But I thought this was a nice example of almost identical to the left eye, the healthier eye of your patient. It kind of a similar appearance there. So, and that's all.
Yeah.